Dr. Moura, who will show us how to evaluate pulmonary regurgitation. It's very important to take a look at morphology because this may be helpful regarding the etiology or the mechanism of the pulmonary regurgitation. She will then move to the different parameters that we have to evaluate to assess the severity of the pulmonary regurgitation. And finally, she will talk about the consequences of the pulmonary regurgitation on the right ventricular cavities and of the limitations of these techniques to evaluate the right ventricle.
The echocardiographic assessment of a patient with pulmonary regurgitation may be quite challenging for two reasons. First, because the pulmonary valve is more difficult to visualize by echocardiography in comparison with the other valves. It has a poor acoustic access. And second, because the parameters that are usually applied for assessing quantitatively the severity of regurgitation have been less validated and are less robust in comparison with aortic regurgitation. Here we have a patient with a tetralogy of Fallot of a 17-year-old. He has underwent correction of tetralogy of Fallot very early at the age of 8 months by a transatrial approach, and has also underwent patching insertion for enlarging the right ventricular outflow tract. And as usually happens, these patients at long term, they develop pulmonary regurgitation, and this is a follow-up examination in order to assess the severity of the pulmonary regurgitation and the consequences on the right heart chambers. So I will start by with a parasternal long axis view, which shows to me a normally contracting left ventricle, morphologically normal mitral valve and aorta. You can see that the right ventricular outflow tract is significantly enlarged, and there is also a hyperechogenic part here at the level of the septum membranosum, which we can see better by going one costal space above, like this, in order to see better the aortic root. And you can see this hyperechogenic part, which represents the patch that has been used during the surgical intervention to close the interventricular septal defect. If we add Doppler, we will see that there is no residual shunt at this level. If we will go then to assess the morphology of the pulmonary valve, we need to rotate the probe into a short axis view, and then we will be able to have a focused examination of the pulmonary valve and the pulmonary trunk with the right and the left branches. And you can see that there is a clear lack of coaptation of the cusps of the pulmonary valve. However, in this view, we are only able to see just two of them because this is two-dimensional imaging. If we want to assess the severity of the pulmonary regurgitation, we need to add the color Doppler flow imaging on this image, and we will have an immediate evaluation of the severity of the regurgitation. There is no need to quantitate. Just by looking at this image, we have several informations. So first of all, if I will freeze this image, I will see that in diastole, the regurgitation originates at the level of the right branch of the pulmonary artery, as you can see, and this is highly specific for a severe pulmonary regurgitation. If the origin of the pulmonary regurgitation is more proximal, more closer to the valve, for instance, of the bifurcation, or at the level of the pulmonary trunk, this is correlated with a moderated degree of pulmonary regurgitation. So just a qualitative assessment of the color flow and the origin allows us to have a quick conclusion of the severity of the regurgitation. If we would like to confirm that the origin of the reflow in diastole is at that level, we can also add the pulsed wave Doppler exactly with the sample volume placed at the level of the pulmonary, of the right pulmonary branch, as you can see in the upper view. And here you will see a systolic antegrade flow, but in diastole you will be able to obtain a hollow diastolic intense signal, which indicates the fact there is a significant amount of reversal of the flow during diastole, which is correlated with a severe pulmonary regurgitation. Then there are several other parameters that one can use for confirming the severity of the pulmonary regurgitation from color Doppler imaging. And another one is the ratio between the vena contracta and the right ventricular outflow tract measured exactly at the level of the pulmonary valve. So like in this case, for instance, if I would go and display this image simultaneously side by side with the 2D image, on one side I can measure the right ventricular outflow tract at the level of the pulmonary valve, like in this case, and then I can measure on the collar the thickness of the vena contracta at its narrowest point. You can also remove the collar to see better. And then you can appreciate by performing the ratio between the right ventricular outflow tract and the thickness of the vena contracta. If the ratio exceeds 0.5, 0.65, it is indicative of severe pulmonary regurgitation. There is no defined cutoff for the absolute thickness of the vena contracta in pulmonary regurgitation, but just this parameter of the ratio with the right ventricular outflow tract. Another parameter that may be useful sometimes is the duration of the pulmonary regurgitation relative to the whole duration of the diastole. This can be assessed on qualitatively with the color M-mode imaging. As you can see here, the flow in diastole is red, and its duration is marked by this image here, while during the late diastole there is no color flow, meaning that there is no regurgitation, and we can measure the timing of the ratio between the duration of regurgitation and the entire duration of the diastole. Alternatively, this can be done also with a continuous Doppler wave imaging. Here you have the anterograde flow, which measures, in this case, 2 meters per second, which is reflective of a high volume antegrade volume that is the consequence of this significant pulmonary regurgitation, and it's not an indicative of fixed stenosis, but is a relative stenosis. And in diastole, you will see the envelope, the signal, which is intense and has a steep deceleration in diastole, which reaches 0 before the end of diastole. And there is also the so-called the PR index, the pulmonary regurgitation index, that can be measured by computing a ratio between the duration of the pulmonary regurgitation, like this, which is almost 500 milliseconds, and then you can take another duration to measure the entire duration of the diastole. If the ratio between the first and the second is less than 77%, it is specific for severe tricuspid regurgitation. However, it must be said that the duration and the length of the pulmonary regurgitation is not only influenced by the severity of the regurgitation, but also by the diastolic properties of the right ventricle and also by the pulmonary pressures. So this sometimes may be misleading, and another parameter that can be used on the continuous wave Doppler is the PHT, so the pressure half time, which can be measured in this way using the modal velocity. So we can measure this interval, in this case is 129. If the PHT is less than 100, it is again highly suggestive for a severe pulmonary regurgitation. So most parameters in this case tend to suggest that the pulmonary regurgitation is severe. Now let's take a close look to the right chambers and on the consequences of this volume overload on the right heart. If I will see from this position the short axis view, I can appreciate the motion of the septum and the septal flattening in diastole, which is indicative of the volume overload, and also on the interdependence that it is related to the high pressure in the right ventricle, which impacts on the septum and produces a diastolic dysfunction on the left side. Then if we will move in the apical view, we will be able to see that there is a significant enlargement of the right heart cavities, because only qualitatively we see that the dimension of the right ventricle exceeds the dimension of the left ventricle. If you would like to assess more closely the performance and the dimensions of the right ventricle, we need to focus and obtain a dedicated view of the right ventricle, and on which we can perform the measurements of the areas in order to compute the fractional area change. So for measuring the largest dimension, we need to select the end diastolic frame and then select area trace, and then going to trace manually the endocardial border, making sure that all trabecular part of the wall are included in the cavity, like this. And then we close at the level of the tricuspid annulus. In this case, the area is 54, so is indicative of very severe dilation of the right ventricle, because the normal value is around 28 centimeters square. If we have the possibility to perform also 3D echo imaging, it is recommended, because it is more accurate and more reproducible, especially in patients with congenital heart diseases, and nowadays it is the recommended method for assessing the performance and the size of the right ventricle. For performing this examination, we need to select the 3D probe. Okay, then go into the apical approach, and then select the multi-slice display of the right ventricle, in which we are able to see that there is a significant enlargement of the right ventricle, and with also a significant right ventricular dysfunction. The 3D probe in this case can help not only for assessing the morphology and function of the right ventricle, but can be used also for taking a closer look to the valve morphology. And we can go now to look at the pulmonary valve from the parasternal approach. And keep in mind the fact that the 3D probe can be used also for the biplane imaging, not only for 3D rendering. So you can have a very quick appreciation of the morphology of the pulmonary valve in two perpendicular views side by side, and here you can see very nicely the lack of coaptation, and this is confirmative of the mechanism of the pulmonary regurgitation, which is organic in this case. So there it's a primary pulmonary regurgitation, is not related to the dilation of the trunk of the pulmonary artery or to the increase of pulmonary pressure, but it is clearly related to an abnormal morphology of the valve itself. In biplane imaging, then if you want, you can also add color Doppler imaging to have a larger, more comprehensive visualization of the flow, of the regurgitant flow. And this view here confirms that the regurgitation is severe, and if we will stop the color Doppler in diastole, you will be able to see that actually the regurgitant flow fills the entire pulmonary artery and the right ventricular outflow tract. So this is a clear sign of severity. And then if you want, even if it's challenging, and it is most challenging to assess from transthoracic approach among all the valves, but we can try if the quality of the images is appropriate. We can try to obtain en face view of the pulmonary valve, like in this case. Here the point of view is from the pulmonary artery, and you can appreciate from this image aside that there is lack of coaptation in the diastole. If I will freeze the image, here you will see a hole here, and if I will play the image, you will see that only 2 of the 3 cuffs are visible. So the morphology of the valve is indicative of a primary cause of the pulmonary regurgitation. If after all this comprehensive examination you are still having doubts about the severity, there is also the possibility to compare the by pulsed wave Doppler, the VTI, the velocity time integral from the pulmonary valve and from the aorta. And if there is a significant discrepancy between the two, meaning that the pulmonary flow is significantly larger than the aorta, this is again an indirect sign of the severity of the pulmonary regurgitation. For doing this parameter, I will switch again to the 2D echo imaging. Then going to parasternal view, I will take this flow with a pulse wave Doppler, the antegrade flow of the pulmonary valve, across the pulmonary valve, and we can measure the velocity time integral, again using the modal velocity, like this. And you will obtain a number 35, which is significantly large. And then from the apical approach, we take the same type of acquisition across the aorta. And if we do the measurement, we will find, also visually you can appreciate that it is significantly smaller. And you will find a VTI of only 23 centimeters. So again, this is a confirmatory sign of a severe pulmonary regurgitation. So this is overall the semi-quantitative and quantitative assessment that can be done when scanning a patient with pulmonary regurgitation. PISA method can be tried, but is never validated as for the other valves, and there is no clear cutoff. This is why I have not presented it. The most important and most specific parameters are the origin of the regurgitant in the branches, which is highly specific, and also the ratio between the vena contracta and the right ventricular outflow tract. again, integrating all these findings in the clinical context and also with the informations provided by 2D and 3D echo related to the size and the function of the right ventricle will help you to reach the proper conclusion about the severity of the pulmonary regurgitation.
So the conclusion of this topic is that, of course, it's very challenging to assess pulmonary regurgitation, and moreover, it's very important to integrate all the different approaches and views to have a good evaluation of this pulmonary regurgitation.